Mhm. Dear colleagues,
And the challenge is to be working in small calcified vessels, non-elastic, uh, and without causing trauma. The success depends on the gentle strategic technique. And the decision making often is very complex because we have plenty of options, multiple combinations, and the problem is the comparative effectiveness remains uncertain, particularly in the long term outcomes. On top of this, we have multiple factors like the runoff and the outflow, the type of plaque we are treating, the regional availability, and even the insurance coverage. So many times, the operators, we find ourselves as chefs. We are trying to find the best ingredient for the final recipe, but at the end, we are cooking the same meal. So probably what I am doing is not the same that you are doing in your cat labs. There are several factors, but at the end, we must individualize our decision making. Because of the extensive armamentarium, let me start what is not working, and probably everybody in this room agrees. POVA. Simple POVA is not enough in BTK vessels because this is associated to the three biggest enemies in BTK intervention: dissection, recoil, and restenosis. And I'm going to leave here uh, the reference of this fantastic paper that has been released recently, hot from the press. But when we mix POVA with the small vessels, high calcifications, the delivery of the drug will be very poor. The result will be a poor long-term outcome that will be translated into this, a major amputation. So having my head very clear, POVA is not working. Let's review what I believe it is working BTK. The IBUS. I believe IBUS is essential for BTK imaging because the angiography, it is underestimating the vessel size up to 25%. It is missing dissections up to 8 times. Instead, the IBUS is providing a proper vessel size, is allowing us to see the plaque morphology, the distribution. It is identifying dissections, and at the end is allowing us to do a proper vessel balloon selection, and it's allowing a proper and safer interventions. The shockwave, I believe it is an excellent tool for the back calcium and to modify the vessel to increase and gain vessel compliance. It is very easy to use, user friendly. The curve for learning it is very low. We can even use it in the subintimal space. And we have very consistent data from the Disrupt PAD3 subgroup analysis, which is the largest real-world IBL experience in calcified BTK lesions. Another excellent tool, under my opinion, it is the orbital atherectomy. The learning curve probably it is longer, but in expert hands, like the case we are seeing here, it is allowing us to debulk calcium even from the pedal vessels with excellent results, like the case we can see here, images courtesy of our colleague Dr. Mariano Palena, with a final beautiful result on a pedal plantar loop. Another way to debulk, in this case, mixed and fibrotic plaques, it is the laser atherectomy. I think it is an excellent choice for fibrotic lesions, restenotic, and in-stent stenosis. In this case, for example, we have a very good candidate. He was presented mixed fibrotic cases, not very high load of calcium, so we choose for him laser atherectomy paired with Limus DCB with excellent result. But I think the problem is the cost, and it is not available in all the CAD labs or hybrids. What is promising? Javelin crossing device, unfortunately, is not available yet in our region. Specialty balloons, we have seen many of them in the excellent talk of Dr. Rufino before, and the novel drug reabsorbable scaffold and the retrievable scaffold, such as the Spore. As we have seen before, the specialty balloons, there is plenty on the market, but I believe they are designed to be treating mixed and fibrotic plaques, not highly calcified lesions. I think the most remarkable ones now available in the market are the Austral Core, the Chocolate, and the Serenator. All of them, they are based in the idea of doing a controlled dilation, reducing the dissection, reducing the recoil, modification of the plaque, proper delivery of the drug, and at the end, increasing the patency. I believe right now the best of them in the market for BTK disease is the Serenator in combination with Limus DCB. The retrievable scaffold therapy, the SPUR, I think it is a very smart strategy. Again, not available in our region yet, but it has shown that the tibial recall can be reduced up to 60%, showing patency of 86% at 6 months if we are associating it again with limus. Again, we cannot use it in very calcified vessels, but I think it is a good option for mixed and fibrotic plaques. Finally, last but not least, the drug reabsorbable scaffolds. There is different platforms. In Europe, they have the motif, and now they are introducing the split BTK. What we have here in our region is the split BTK. Recently, very promising data was presented in the TCT. 3 years result coming from the live BTK that was showing very good patency rates and low intervention after 3 years compared with POVA. At the end, it's giving us whatever we want in theory. We inhibit the neointimal hyperplasia thanks to the drug delivery. We will minimize the recall thanks to the presence of the scaffold, and eventually we will leave nothing behind. Of course, there are limitations. One of them it is the cost, but I believe it is very promising because it is allowing us to treat different types of lesions: calcified, fibrotic, dissections. Very helpful in chronic and long CTOs to tackle dissections, even in coral-like lesions like these ones. This is a patient that was very high risk, underwent multiple interventions with direct recoil, and if you look at the coral-like lesion, you will understand why. So we decided to treat her with a drug reabsorbable scaffold to provide a longer patency. This allows us to heal a transmetatarsal amputation. This is the stamp and 125 days. We cannot listen to the flow, which was very nice. The complete healing was achieved at 262 days. Next week, this patient will achieve 1 year without reintervention. But again, the cost is very high. I'm going to leave here this reference for the ones that want to read more about the bioresorbable scaffolds. What still fails? Under my opinion, the permanent metal stents below the knee because of the fracture and re-stenosis also are limiting our options for future interventions. And personally, I believe the rotational and directional atherectomy devices are not the best choice in small lumen vessels because of the rates of embolization, perforation, and dissection. I believe they work very well in the FEMPOP sector, but it will not be my first option below the knee. But to be fair, there are groups that have high volumes and they have reported in the literature excellent results without complications, like paper I'm showing here from the group from Konstantinos Donas in Germany. And to finish, I would say, like in below knee vessels, right now with all the extensive armamentarium we are having, we should provide or we must provide our patients tailored plaque therapy. We are seeking precision over force. POVA is not enough. You need to think more about what you're providing to your patients. Adopt IBUS as BTK imaging. Consider calcification modification to improve your outcomes and favor temporary scaffolds over permanent stents. Don't leave metal below the knee. We are treating millimeter with arteries to save limbs, and every detail matters. Thank you very much for your attention.
Thank you, Tania. And now for the last topic in this session, we are welcoming Dr. Mohammed Al-Garni. He is talking about managing of popliteal artery aneurysm